Good afternoon, everyone. Welcome to the Lynch Syndrome Management webinar, which is being organised by the East Genomic Medicine Service Alliance. I am Melissa Cambell-Kelly. I'm an associate nurse with the East GMSA based at the Norfolk Norwich University Hospital. If we can just ask everyone to turn their cameras off and their sound off, please. And if you can keep those off and type any questions into the chat. And I have some colleagues that are checking the chat, and we will ask our speakers as and when we can. And we have got a Q&A session at the end at 10 to 1. We have still got people joining, but we have got a packed schedule. So we will start, and I'm going to hand you over to our first speaker, who is Vicki. Thank you, Vicki.
Thank you very much, Melissa. So my name is Vicki Kiesel. I'm the lead genetic counsellor at L&R Genomics Medicine Service and also the East Midlands Lynch Syndrome lead for the GMSA. I'm going to talk to you about implementing Lynch syndrome, where we are at the moment and where we're going in the future. So most people on this call, I'm sure, will know that there's an estimated 175,000 people in the UK with Lynch syndrome, which means that about 1 in 350 people have the condition. It leads to over 1,100 colorectal cancers a year and is responsible for 3% of all colorectal and endometrial cancers. I'll talk about this in more detail, but the tumours are usually identified by the absence of one or two of 4 proteins identified by immunohistochemistry, also known as IHC. So what are the risks of Lynch syndrome? The overall risks of colorectal cancer are between 10 to 57%, so quite a range. The risk of endometrial cancer is 13 to 49%, gastric cancer is 13 to 19%, and ovarian cancer is 9 to 12%. And there are a number of other smaller risk cancers associated as well. But in reality, although those are the overall cancer risks, they're actually quite gene specific. So this breaks it down in a lot more detail. The genes MLH1 and MSH2 have substantially higher cancer risks than the other 2 genes. So the overall highest risks are 57% risk of colorectal cancer, and that's in males with MLH1 mutations. Males with MLH1 mutations also have a 22% risk of upper GI cancer. While if you move over to the MSH2 gene mutation carriers, females have a 49% risk of endometrial cancer and a 17% risk of ovarian cancer, while men have a 24% risk of prostate cancer. So people with these 2 genes have significantly higher risks than the other 2 genes. If we go to the next slide, please. So MSH6, while women do have a 41% risk of endometrial cancer with this gene, in general the cancer risks are lower, and they're significantly lower with PMS2, to the point where we don't really have significantly raised risks of most cancers. For PMS2 carriers, we are very much thinking about colorectal and endometrial cancers only. Next slide, please. So identifying those at risk. Although, as I've said, it's relatively common, 95% of people with Lynch syndrome are undiagnosed. And even when a family has been diagnosed with Lynch syndrome, unfortunately, they're not always appropriately managed. The reason that this has become such a national push is because it's a relatively common condition. And as I've just said, most people don't know that they have it. This is a picture of a gentleman who very sadly passed away from colorectal cancer at the age of 19 in 2014. He had a family history of Lynch syndrome, but unfortunately he still passed away. Next slide, please. So because of the underdiagnosis of this condition, in 2017, NICE recommended that all colorectal cancers should have some form of molecular testing, either with MSI or IHC. Either was thought to be equal. And then in 2020, NICE recommended that all people with endometrial cancer should have IHC testing. There is a slight difference there that they didn't recommend MSI testing. They said that it would be preferable to have IHC testing. So since then, there has been a national push, and the plan is that we should be delivering this testing across the whole of endometrial and colorectal cancer, and this is supported very much by the National Transformational Project, which is led by the North Thames and South East GMSAs. We also have a national oversight group which meets monthly in order to deliver the Lynch syndrome pathway. Locally, our cancer alliances led by Sally Pitkin in EMCA, and also the genomic expert clinical advisory groups have been supporting this, as have the 7 GLHs, the genomic laboratory hubs, and the 7 genomic medicine service alliances. And obviously we do all of this based on the National Genomic Test Directory, which tells us which patient should be offering, which patient should be offered which genetic test. Next slide, please. And that's just showing you the criteria for the Genomic Test Directory. So despite the criteria now recommending that somatic testing is offered on all colorectal and endometrial cancer, national and local audits have suggested that only 1/3 of abnormal IHC or MSI results were actioned, meaning that 2/3 of people with potential Lynch syndrome didn't know about it and therefore clearly weren't having the correct testing, neither were their family members having the right screening. So this year in February, there was the statement that came out by the quality standards stating that there should be a local Lynch syndrome lead in all the MDTs. IHC, again, should be performed on all colorectal cancer with reflex to either BRAF or MLH1 methylation where necessary. And crucially, that healthcare professionals must be aware of local protocols and when to refer them. So the quality standards went one step further, saying it's not just good enough to do the somatic testing, but it's also crucial that MDT staff are aware of the testing and what to do with it. The NHS England priorities also said for 2022-23 that it's vital that we ensure that every person diagnosed with colorectal and endometrial cancer is tested for Lynch syndrome, and that cascade testing is offered to their family members. Next slide, please. So when we have a person with colorectal cancer, the plan, and in most trusts what actually is happening, is that mismatch repair immunohistochemistry, or MMR IHC, is performed on the endoscopic biopsy. So at the very first point of diagnosis, on the very first biopsy, IHC testing should be performed. And then dependent on the results, different pathways are followed. So if there's loss of MLH1, that occurs in 15% of sporadic tumours. So MLH1 itself is not indicative of Lynch syndrome and further testing is necessary. The first step that's usually done is BRAF testing, because if there's a mutation in BRAF, then it's probably sporadic. If BRAF testing is normal, then we can go on and do methylation. If methylation testing for MLH1 is also normal, then it's quite likely that that patient has Lynch syndrome. So when all of that's followed, or when there's a loss of any of the other 3 gene proteins, then we would offer germline testing. We would also offer germline testing to anybody under the age of 40 with colorectal cancer. So essentially this flowchart shows you what we should be doing with all new diagnoses. And the plan being that hopefully everybody with Lynch syndrome will be diagnosed. Next slide, please. So the only difference for endometrial cancer is that BRAF testing is not helpful. So we do not do BRAF testing for endometrial cancer, we go straight to MLH1 methylation. So depending on the pathway, the pattern that we see on IHC, that determines what testing we'll do next. If there's absence of MSH2 with or without MSH6, or if there's absence of PMS2, we would go straight to germline testing. The likelihood is that that is caused by Lynch syndrome. Whereas if we see deficient MMR IHC where there's absence of MLH1, that occurs in 15% of sporadic tumours. So absence of MLH1 on its own is just an indication we need to do more somatic testing. For colorectal cancer, the first step is BRAF. For endometrial cancer, the only step is MLH1 methylation. And we don't care about family history questionnaires. I know in genetics we've been going on about family history questionnaires for decades. This is the one situation, or one of the situations, where we don't care whether they have a family history or not. If there's absence of IHC showing the correct pattern, they'll offer germline testing. Can I have the next slide, please? So at present, germline testing is done in clinical genetic services. However, due to our long waiting list, this can cause unnecessary delays, and we very much hope in the future that we'll be able to support mainstreaming, which is where the actual germline testing is done within the MDT. So the plan being that we will work with all the MDTs in order to support people to do germline testing when the correct pattern is shown, to speed up this testing and to identify as many people with Lynch syndrome as possible. Next slide, please. So for people who are interested or already doing mainstreaming, what this involves is genetic counselling. So it involves giving an information sheet to the patient, which of course we have and can provide you with. They do need to take a very brief family history, just so we know who we'll be talking to if the cascade testing is necessary, and then discuss what Lynch syndrome is and the 3 possible outcomes. Just to reiterate, the 3 possible outcomes of germline testing are 1, that we find a mutation, 2, that the test is normal, and 3, that it's uncertain because of variants identified. The next step in mainstreaming, after taking the consent, of course, is to arrange a blood sample, and then when the results come back, briefly explain the results to the patient. Anybody with a variant or a mutation should be referred to genetics, and we'll take forward the counselling and the referrals at that point. Next slide, please. So in terms of how we can support MDTs, we do have some funding for administrative support to track IHC and methylation. I know in some trusts that's a bit of a problem because, of course, a lot of these patients may have been discharged from their MDTs by the time the methylation comes back. So this is something we can help with. We also do have some funding in East Midlands for clinical nurse specialists to provide the mainstreaming. But fundamentally, what we're here for is to help train, teach and support people. We also have lots of SOPs and patient information to provide MDTs with any information that they may need. Next slide, please. So what we need from you, and what we'd be very grateful for your help with, is if you don't already have an identified Lynch syndrome champion, please do nominate either yourself or a colleague. We need a Lynch syndrome champion in every gynae and colorectal MDT. We also do need our Lynch syndrome champions to please complete the RM partners training. It is actually quite useful and interesting training, but crucially, please can you complete the assessment at the end of it so that we do have a record of you completing the training. We also need every MDT to have robust SOPs. We have standard SOPs for the region, but most likely they may need adapting to your personal MDTs. We also need to make sure that IHC is routinely performed on all tumours and the appropriate reflex testing is happening. This is happening in most trusts. If it's not happening in your trust, then we're here to help you and would like to support you setting that up. What's not happening in a lot of MDTs is that these test results, whilst they might be happening, they're not routinely being discussed in all MDTs. And we do really need to make sure that all abnormal IHC is discussed and management plans are documented. Long term, we would very much like to support you to arrange mainstream testing. However, there are some smaller MDTs which don't have the facilities to do that, in which case we'll be happy to continue to accept referrals to genetics. Next slide, please. So the long-term future, or not too long, the short-term future, is that all patients with abnormal IHC will be discussed in MDTs. So everybody with abnormal IHC will come back if they have been discharged. Germline testing and consenting, we hope, will occur in all the MDTs. Once all these Lynch syndrome patients have been identified, they will be referred to the Lynch syndrome expert hubs that we're setting up. There'll be one in Cambridge and one network across Nottingham and UHL. All Lynch syndrome patients are going to be discussed at these expert hubs, and we'll make sure that they're referred to the appropriate people locally. So if they haven't been referred to a gynaecologist, for example, then we would work with the local teams to ensure that occurs. And from April next year, colonoscopic surveillance will be arranged automatically by the National Bowel Screening Programme, and that will be arranged 2 yearly. So hopefully that will be a lot more consistent and effective than the current system that we have. Next slide, please. That's the end of my slides. Does anybody have any questions before we move over to Ruth, who's going to talk about the management of Lynch syndrome?
Come in, Vicki, if that's okay.
I'm sorry, I missed that.
Can I come in if that's okay? Kelly Lambert, breast surgeon and associate medical director for cancer at UHL.
Yes, of course, please do.
Thanks for your presentation. It's really interesting and also exciting and great for the patient. I just wanted to come in on a point I raised in the chat that you've mentioned that there's a degree of funding available for CNS's presumably to undertake this work. I'm conscious that this group of clinicians are already very stretched with their core activity. So I wondered what the degree of funding was available and whether or not other models have been looked at, for example, training a group of AMPs looking at Lynch and maybe other things in other units.
That's a very good point. CNSs are incredibly stressed. So it is very trust dependent. So it doesn't have to be that group of healthcare professionals because, as you've said, they're trying to do so many different things at the same time. There are other models in other trusts across the country, and we'd be very happy to support any other model that would work within the trust. In terms of the funding, it is regional dependent. So in the East Midlands, we have hang on, I'm just thinking, 4 PAs across each trust, so 2 PAs per MDT, but that is only in the East Midlands. And as I said, it doesn't have to be specifically for CNSs, it can be for any healthcare professional group to provide the mainstreaming. I hope that answered the question.
Yeah, thank you. I'm just hoping it's enough, but thank you very much.
In terms of numbers, we are actually only talking about 3 germline tests a month, roughly.
That's reassuring. Thank you.
I can see somebody else has their hand up, but I can't see who.
I have my hand up. It's Philip Kay speaking, pathologist, GI pathologist in Nottingham. Can you hear me?
I can, yes.
Yeah. So as you may know, Nottingham were very late to implement Lynch syndrome screening, but we are doing it now for all colorectal and endometrial cancers. But I think we do, I think, have a problem in communication in getting the results back, and it's certainly not discussed at our MDTs. And I think it might be a hard sell to actually get these cases to be discussed at the MDTs for every abnormal test. I'm just wondering if there's a way of doing it without actually having a formal discussion on each case. But is there not a particular pathway that these patients should go down rather than actually requiring discussion of each case?
So I think Lizzie Smyth will answer this question a lot better in her talk. But I think one of the reasons that we want these patients discussed is because it may, if we get the results in time, determine their surgery. Instead of doing a segmental resection, people may decide to do a subtotal colectomy, and also it will affect whether they have immunotherapy or not. So ideally, we would like them discussed at MDT.
Yeah, I mean, they always request the immunohistochemical testing, but in terms of the results of them actually being, I mean, and we're under a lot of pressure, obviously, to get the biopsies back and discussed at the MDT. So obviously, the cases generally get discussed before the immunohistochemistry is done. So it would actually mean each case would have to have, each abnormal case would have to be discussed a second time.
Yes, potentially that is what would need to happen in some situations. I suppose the thought is, and I'm talking about only the patients where there is no MLH1 methylation, not just all the abnormal IHCs, that those patients will have a very high risk of having Lynch syndrome, and we wouldn't want them missed. It may be that some trusts need to have a different setup, but certainly every one of these patients does need to be picked up.
Okay, so just the ones without MLH1 without methylation. Okay, although of course that takes, in our experience, that takes weeks to come back. So generally, patients' management plans will have already happened by then.
Yes, I mean, one of the problems is that MLH1 methylation is taking a long time. I know that Cambridge is hoping to centralise this in time and will hopefully speed that up. But that is certainly one of the problems that we have and the challenges, which is one of the reasons why we're looking at potentially trying to support people to track these results, because that is another one of the challenges.
Well, that would be very useful if we could get somebody to do that. Thank you.
Thank you. Melissa, do jump in if we need to move on, but I can see there are a number of other hands.
Yes, we do, please, Vicky. Can we ask anyone who has got a question to add it to the chat? We will pick it up at the end of the session when we have a Q&A session. So if we could ask Ruth to present next, please.
Thank you. Can you see that, Melissa?
Yes, we can see that. Thank you, Ruth.
Lovely. Well, good afternoon, everybody. My name's Ruth Armstrong, and I'm one of the consultants in clinical genetics at Addenbrooke's, and I'm also the East GMSA Lynch Syndrome lead. So Vicki has spoken about how we identify those people and patients with Lynch syndrome. But what do we do once we know that they have Lynch syndrome? What can we do to reduce their risk of developing cancer and keeping them healthy? Fortunately, there are a number of interventions that can significantly reduce the risk of developing cancer and or provide effective early treatment if it does develop them. And these include giving information on healthy lifestyles, symptom awareness, reproductive options, cascade testing, daily aspirin, H. pylori testing and eradication, screening, surgery, and immunotherapy. Firstly, education is not only important for healthcare professionals, but it is essential for patients and families. We know that information empowers people to manage their own health and leads to significant health benefits. Once someone has been diagnosed with Lynch syndrome, it is important to signpost them, their families and clinicians to the abundance of information that's available. And RM Partners have developed a wonderful package and some very informative short videos regarding Lynch syndrome for both clinicians and families. There's also local resources such as patient information sheets that are shared with the patient, GP and clinicians on diagnosis. And there's also Lynch Syndrome UK, which provides excellent support for both patients and clinicians. And they currently produce a patient passport that aids follow-up, but they're also working with Professor Julian Barwell in Leicester to develop a patient-held app. So current evidence suggests that advice related to weight, some dietary habits, physical activity that we recommend for the general population is also relevant to those with Lynch syndrome. However, prospective and randomised controlled trials are required to determine whether more tailored recommendations are needed. And the Macmillan website provides excellent information on cancer risk reduction for all. So everyone should remain cancer symptom aware and report concerns to their doctors for further assessment. And it's so important that clinicians have a low index of suspicion and investigate accordingly in those who are at risk of Lynch syndrome, even in the really young patients. If a person has Lynch syndrome, there's a 50% or 1 in 2 risk that each of their children will also inherit Lynch syndrome and be at risk of developing cancer. But there are a number of options that are available that can be discussed with the local genetics team. Invasive prenatal testing, such as chorionic villus sampling and amniocentesis, is not commonly requested, but pre-implantation genetic diagnosis is available and helpful to some families. Once the first case of Lynch syndrome has been diagnosed in the family, predictive counselling and testing is available for unaffected family members. And people with a new diagnosis of Lynch syndrome are usually given a letter to share with their family by the clinical genetics service, so that adult family members can take this to their GP and request a referral to their local genetics service for predictive counselling and testing. There are several biological mechanisms through which aspirin may exert its anti-cancer effect, and the CAP2 research study showed that 600 milligrams of aspirin a day almost halves the risk of cancer for people with Lynch syndrome, and the CAP3 research study is currently ongoing to determine the most effective dose. Pending that, NICE and we recommend that people with Lynch syndrome take 150 milligrams of enteric-coated aspirin once daily, or 300 milligrams if their BMI is over 25, between the ages of 18 and 65. Most patients will buy over the counter, but we reiterate that it's really important to inform their GPs and hospital doctors and check if there's any contraindications or drug interactions. And NICE provide excellent guidance on this, and there's also a patient decision aid available as well. So testing for H. pylori and treatment if infected is indicated from 25 years onwards, and there's several different testing methods depending on location and availability. It's usually a one-off test with further testing if the patient develops heartburn or any symptoms suggestive of H. pylori. And there's some evidence to suggest that it reduces the risk of gastric cancer by up to 50%. Screening also plays an important role in reducing the risk of cancer and detecting it early, thus allowing more effective treatment. Colonoscopy, bowel screening is recommended 2 yearly from the age of 25 for those with MLH1 and MSH2 pathogenic variants, and from 35 if they carry an MSH6 or PMS2 pathogenic variant. The upper age limit is very dependent on comorbidities and patient choice, and we know that colonoscopy can halve the incidence of colorectal cancer and mortality. It's also important that patients participate on the NHS bowel screening, and there's ongoing research to determine the effectiveness of FIT testing in Lynch syndrome. Gynecological screening is slightly more controversial. There's an excellent consensus statement by the Manchester International Consensus Group. We recommend that women with Lynch syndrome are offered a referral to a gynecologist to discuss risk reduction at point of diagnosis. We know that ultrasonography, biopsy and hysteroscopy can detect endometrial cancer, but there's no evidence to say that it actually leads to an improved survival. Screening for ovarian cancer is not effective or indicated. The consensus guidelines suggest that women with Lynch syndrome have an annual appointment with a gynecologist for a detailed symptom inquiry, discussion regarding the timing of risk-reducing surgery, a review of contraceptive and fertility needs, and advice regarding cancer risk-reducing behaviours from the age of 25. Any woman with any red flag symptoms such as abnormal bleeding and bloating, etc., should be referred to a rapid access clinic for prompt assessment. So other screening in Lynch syndrome is currently not recommended unless within the context of a research study, and there's a number of studies that we can offer patients recruitment to, such as Europac, Impact, and hopefully there will be a new study looking at MSI to detect early urothelial cancers later on next year. And we recommend that all women are encouraged to participate on the NHS breast screening and cervical screening programme. Thinking about surgical management, in patients with MLH1 or MSH2 pathogenic variants who develop colon cancer, the decision to perform segmental versus total or near colectomy should balance the risk of metachronous cancers, the functional consequences of surgery, and the patient's age and wishes. And this is why it's so important that the patient gets a timely result in relation to potential Lynch syndrome. In patients with MSH2 or PMS2 pathogenic variants, there's insufficient evidence for oncological benefit of extended colectomy over segmental section. So surgery for women with known Lynch syndrome who present with endometrial or ovarian cancer undergoes standard surgical treatment with hysterectomy and bilateral salpingoophorectomy. And there's limited Lynch specific literature regarding this, but as most of it really focuses on risk reducing surgery and testing for Lynch syndrome at time of diagnosis. But women with Lynch syndrome should be offered a referral to a gynecologist to discuss prophylactic surgery at an appropriate age. So for women with MLH1, MSH2 and MSH6 pathogenic variants, we recommend that this is around the age of 35-40 following the completion of their family. And the timing is very dependent on other risk factors, and it can be staged depending on the age and acceptability of HRT post-surgery. For women with PMS2 pathogenic variants, the strength of evidence is insufficient to strongly recommend risk-reducing surgery, but they still may benefit from a referral to the gynaecologist for an individualised assessment and discussion. So in summary, there are a number of interventions that reduce the risk of cancer for people and families with Lynch syndrome. It is therefore vitally important to identify those at risk in a timely fashion to ensure appropriate management is offered and to raise awareness regarding red flag symptoms and when patients and clinicians should seek urgent advice and further investigation. Thank you.
Thank you, Ruth. Lizzie, would you like to present, please?
Thanks, everyone. Nice to see you today. My name is Lizzie. I'm a medical oncologist in Cambridge. I'm the cancer lead at the GMSA, and today I'm going to talk briefly about why Lynch is important for chemotherapy and also for immunotherapy treatment. I think I was scheduled for 15 minutes, but I'll bring it a little bit shorter so that we have time for questions as I have a hard stop at 1 o'clock, unfortunately. So the key science behind the fact that the biology of Lynch tumors are different from non-Lynch tumors is that because they have defects in DNA repair, patients who have Lynch syndrome tumors have lots of mutations in the tumor. So they're what we call hypermutated, many more mutations than a normal cancer. And what that means is that those mutations make proteins on the outside of the cell, and the immune system sees those proteins and is very attracted to the tumor, at least in the early stages of cancer. So stage 1, 2, and 3 Lynch tumors have a very good prognosis compared to non-Lynch tumors. And that's primarily because they're well seen by the immune system. And what we see if we remove a Lynch tumor is that often it has a very brisk lymphocyte infiltrate. So it's infiltrated by lymphocytes, which are trying to get rid of the tumor because they see those abnormal proteins on the outside of the cell. And what that means is that if we just remove a Lynch tumor that's early stage, especially a stage 2 or 3, even without chemotherapy, often they have a very good prognosis, which means that they're not so likely to recur. And that's important because in particular with GI tumors, Lynch tumors, because of their DNA repair defect, are quite resistant to many forms of chemotherapy, including the chemotherapies that we use in bowel cancers. However, on the other side of that, because they're already well seen by the immune system, they're very sensitive to a new type of treatment called immunotherapy, which we are increasingly using instead of chemotherapy for these patients. So if we could go to the next slide, please. So probably the most common tumor that we see in Lynch patients is MSI, or mismatch repair deficient colon cancer. And you'll hear us variably refer to mismatch repair deficient or MSI tumors. And it both means the same thing. They're just different ways of assessing it. MMR is what we use measuring protein, or IHC. That's what you most often discuss in your MDT. And MSI is when we look at the DNA using PCR. So was there a slide before that at all? No. No, okay, that's fine. So I must have deleted one by accident. So what we know about stage 2 colon cancer, which is MMRD, and that's about 1 in 6 patients. So it's quite common in older patients, in tumors of the right colon, but we're testing all the patients now, so we find lots of them. is that for stage 2 colon cancers, and those are the ones that we normally just use 5-FU alone for, or capecitabine, that those tumours are completely resistant to 5-FU. So first of all, their prognosis is excellent if we just remove them surgically. Second, in clinical trials, there's no benefit to 5-FU chemotherapy on its own. So most stage 2 Lynch tumours or sporadic mismatch repair deficient tumours, which are more common than Lynch, we don't offer chemotherapy to because there's no benefit. First of all, the prognosis is excellent. Second of all, the chemotherapy doesn't work. When it comes to stage 3 tumours, sometimes we would use one drug at a time, which is 5-FU, especially in older patients, but we know that doesn't work in Lynch tumours. However, we do know that for stage 3 Lynch tumours, if we add in another drug called oxaliplatin, that there is a benefit to adjuvant chemotherapy. So that means if a patient who has Lynch colon cancer, who is node positive stage 3, comes through the MDT, they will be offered 5-FU and oxaliplatin chemotherapy because we know that the 5-FU alone isn't helpful for them. So that's how Lynch syndrome status and mismatch repair deficiency status interacts with the outcomes of chemotherapy for colon cancer. And can I have the next slide, please? Now, over the past 2 to 3 years, there's really been a revolution in the treatment of colon cancer, which has advanced. So we're moving on to talk about stage 4 colon cancer now, cancer that would traditionally be considered incurable. So there were a number of early trials which looked at patients who'd been previously treated and treated them with immunotherapy. Now, immunotherapy, usually what we use is an anti-PD-1 antibody, which you'll hear referred to as either pembrolizumab or nivolumab. Those are the two that we use most commonly, or dostarlimab in endometrial cancer. And this is one of the biggest trials that changed practice for patients who were previously untreated stage 4 colon cancer, which is Lynch or mismatch repair deficient or MSI, all really the same thing. And in this trial, which was published in New England Journal of Medicine about 1.5 years ago now, 2 years ago, patients were randomized between normal chemotherapy and the anti-PD-1 antibody pembrolizumab. The treatment was continued until the patients progressed. And really importantly, there was crossover for patients who progressed on chemotherapy because that was considered unethical to not give them what we knew would be an active treatment. Can I have the next slide, please? And so this is the overall survival data for the patients who were treated on the study. Now, it's important to consider that even in the chemotherapy arm, most of the patients got immunotherapy after they progressed on chemotherapy. The normal survival for patients with colon cancer in the UK is less than 2 years. But you can see based on this study that for patients who were treated with pembrolizumab, and that's only one drug of immunotherapy, that at least 2/3 of them were alive at 3 years. So this is a really great treatment for these patients. It has much fewer side effects than chemotherapy. And for many patients, although not all, it does lead to a long-term benefit. And we have certainly cured some patients with immunotherapy who have stage 4 cancer. Can I have the next slide, please? So it's important to know, and I would say that I would focus on the slides here on the images here on the right, that pembrolizumab on its own was a first step for patients with MSI tumours. We're now looking at combinations of anti-PD-1 and anti-CTLA-4. So the anti-CTLA-4 is called ipilimumab, and that should be coming along first line, I think, in the next year or so. At the moment, for patients who didn't have an opportunity to be treated with pembrolizumab first line, we can use nivolumab and ipilimumab, a 2-drug combination second line. And that's even better than pembrolizumab, actually. So you can see that very few patients, 1 year after treatment, 85% of patients were alive. So that's just incredible, even in the second line setting. So it's been a really exciting time to treat these patients with bowel cancer over the past few years. These are our new standards of care, and we have good long-term outcomes, long-term remission, essentially cure for many patients with these drugs, showing how important it is to test all patients for mismatch repair deficiency. Can I have the next slide, please? So the NICE guidance thus far has related to Lynch testing and endometrial and colon cancer, but actually gastric cancer has a good number of mismatch repair deficient patients too. And we certainly implement testing for mismatch repair deficiency in our upper GI MDT. In the localized setting, about 10% of stomach cancers will be mismatch repair deficient. In the advanced disease setting, it's the same as bowel cancer, 3 to 5%. And it does interact both with chemotherapy and with immunotherapy in the same way as colon cancer. So we know that chemotherapy before surgery is less effective for mismatch repair deficient gastric cancer. And we know that immunotherapy in advanced disease is very effective. And in fact, the UK is one of the only countries in the world where we're permitted to use anti-PD-1 immunotherapy first line. So there is no first line registration, but we know that this is an effective treatment. And since COVID, for all upper GI cancers which are advanced, the NHS is funding nivolumab for these patients, so we don't need to give them chemotherapy. So I would urge you, if any of you have upper GI practices, to test mismatch repair deficiency for all your esophageal, gastric, and small bowel adenocarcinoma patients, so we can find the patients who might benefit from this treatment. And the next slide, please. And finally, there's not so much data on the effectiveness of immunotherapy in endometrial cancer, because this was in mismatch repair deficient endometrial cancer. There was one small study, but this did change the practice and the standard of care. So this is the Garnet trial that looked at another PD-1 antibody called dostarlimab in mismatch repair deficient endometrial cancer, and the response rates were very high again, more than 40 to 50%. Most patients benefit, and they actually too have very good long-term outcomes. So in summary, for patients with mismatch repair deficient or Lynch, colon, upper GI and endometrial cancer, we won't find these patients unless we do the test, so we need to look for them in the MDT. What we need to do is consider whether there is an interaction with chemotherapy. We certainly know in colon cancer that we don't treat stage 2 patients with 5-FU. Stage 3, we offer 5-FU and oxaliplatin, and we use immunotherapy for stage 4 cancers across the spectrum with great long-term outcomes. And I'll finish up there, and I think we'll be able to move on to questions.
Thank you, Lizzie. So if anyone does have any questions, could we ask you to add them to the chat, please? And if I could ask my speakers, so Lizzie, Ruth and Vicki, if you could put on your cameras so you can answer any questions that may be asked, please. Thank you. So going up to the questions, there is a question from Kathy Richards. I have concerns that not everyone at the MDTs will understand the MMR findings when the cases are rediscussed. Who needs to be present at the MDT for these MMR discussions? Vicki, you mentioned specialist panels at Cambridge and joint Nottingham-Leicester for MSI case discussion. Who will sit on these?
Thank you, Kathy. So in terms of the local MDTs, I think the crucial person is the Lynch Syndrome champion. And also we are attempting to train and educate the whole MDTs, but the Lynch Syndrome champion themselves will have a lot of expertise and hopefully know how to interpret these. In terms of our Lynch Syndrome expert hubs, we're planning to have a psychologist, a surgeon, an oncologist, pathology representation, hopefully, genetics representation, and then we'll invite, of course, local people to come in as well to present their patients. Ruth, I don't know if you want to add to that.
Well, I agree with what you said, but just to say, if anybody in the MDT ever gets stuck and they can't interpret or they don't understand, you're always very welcome to contact your local clinical geneticist. We're always happy to give advice, whether it be via telephone, email. Please contact us.
Thanks, Ruth. And I would also say that the oncologists in your MDT should at this stage be familiar with the impact of mismatch repair deficiency on the treatment of GI cancers and endometrial cancer. They're all very interested in getting the best treatments for our patients. It can sometimes be tricky that we haven't gotten into sometimes and to talk to pathology about when different proteins are missing, that some patients might need MSI testing as well as mismatch repair deficiency testing. So asking some of the central hubs about that can sometimes be helpful too. So someone has said, does it make any difference to treatment whether the MMR deficiency is germline or somatic? No, the outcomes are the same. So the tumor is hypermutated and behaves as a hypermutated tumor. Of course, it makes a difference for the cascade testing of relatives.
The next question is for you as well, Lizzie.
Sorry,
would you like to pick that
I
up?
just ask a follow-up to that? So the BRAF testing doesn't make a difference to what you do?
No.
No. Okay.
No. Someone asked a question about the MDT. Yes, we do take our mismatch repair deficiency testing into account for FLOT in the MDT. I have treated some patients with FLOT who are mismatch repair deficient primarily because they needed downstaging. We think taxanes work better than platinum and 5-FU, but many of the patients who are mismatch repair deficient are actually quite old and have distal gastric cancers and may not need perioperative chemo, and we have taken some of those out without perioperative chemotherapy. So that's certainly something that we do take into account in the Cambridge MDT.
So we had some earlier questions as well. One of them was regarding funding for CNSs, and could more information be provided about this as the local business case is being developed. So Vicki, would you like to pick up on this first, as you alluded to this, please?
Yes, of course. So the funding, I'm afraid, for CNSs or similar setups is only across the East Midlands. It is slightly different across the east of England. That's because each Cancer Alliance has a certain amount of money to support the Lynch syndrome pathway. And I think the person who asked that question is not in the East Midlands.
No, unfortunately not. They're in the east of England.
Yeah, so the Cancer Alliances were given money from the national team to help embed immunohistochemistry, and some of that money was then used for individual roles within the local cancer MDTs. And of course, we've also got Lynch syndrome nurses that are based in the GMSAs. And there's lots of discussion at the moment going forward, because that initial money was ring fenced. It was pump prime money for 22-23. So 23-24, I think the direction of travel is that we do business cases to the ICSs from each cancer MDT or for each trust, so that we ensure long-term funding for the CNSs, which you have quite rightly said are overstretched and overworked. And it may be that there are other people within the MDT who could also help take on the role. But funding issues, yes, it's tricky. It's still being addressed both centrally and locally.
Thank you. We also had a question about understanding the role of the Lynch syndrome champion. We do have some documentation regarding that, and we'll send that out after this event with the recording and the presentations. But would anyone like, Vicki, would you like to comment on the role of the Lynch syndrome champion? Just a few words, please.
Of course. So I think the main thing is a liaison between MDTs and genetics. So we're just hopeful that the champion can work with us to try and embed the SOPs and help the MDTs understand a bit more about Lynch syndrome. But you're very welcome to contact any of us, and we'll talk you through more of it and certainly support you in any way we can.
Thank you. And then we've had a further question: can Lynch syndrome be picked through the National Bowel Screening Programme, or just following a colonoscopy or gastroscopy?
So I think you're asking, can we detect Lynch syndrome? Or are you perhaps thinking about the early detection of cancers? So yes, you would be able to detect an early colorectal cancer, which would then be amenable to IHC or MSI, and that way you would pick it up. I guess if you're talking about routine colonoscopy or gastroscopy, screening, perhaps for symptomatic patients. I guess if their lesion was found and they were to have a biopsy, again, you would identify that through the initial somatic testing, either MSI or IHC. And I apologise if I've missed the point of your question.
No, you've answered it. Thanks, Ruth.
Thank you, Ruth. We've also had some questions about being sent the documentation. So we are recording this event and it will be uploaded to YouTube. We will also be sending everyone in attendance today the link to this recording, the slides from today's presentations, and the Lynch Syndrome Champion documentation that we currently have. So if anyone what addresses you've registered with from an email perspective, we will send those, because there's been some comments that people don't have nhs.net accounts. That's fine. So whatever you have registered with, we will reply to those addresses. Does anyone else have any further questions? I don't think we've got any more, unless I've missed one. No, I think that's it. Any closing comments from Vicki, Ruth, or Lizzie before we go?
No, thank you all very much for attending. Great to see a high level of interest and 97 attendees online. That's fantastic. Thanks for the invite.
Thank you. So, Vicki? Nothing? No.
Just if you have questions, comments, contact us. We're here to help.
And Ruth?
Nothing further, just to reiterate what Vicki and Lizzie have said, and thank you very much for attending.
Perfect. And as we said, if anyone has got any queries, you've got my email address, just let me know, but we will send the details in a subsequent email, but it may not be until next week. So don't worry if you don't get it before then. We have to upload it to YouTube. So hopefully you've enjoyed the event, and we thank everyone for their attendance. Thank you and good afternoon.
Bye.
Bye-bye.
Thank you.
Bye-bye.